Hello, good evening, everyone.
Hello.
Hello.
Good evening.
Nice to meet you.
Same here.
Nice to meet you.
Hello.
Hello.
Good evening, everyone.
Hi.
Good evening.
Good evening.
Hello, good evening.
Good evening, sir.
Hi, James. How are you?
I'm good, thank you.
Yeah, James, met with Dr. Veda from Indonesia, Dr. Bipul, Dr. Ruhi, and Dr. Salma from BIOS team.
Hello, nice to meet you
Hello.
guys.
Hello. Hello.
So, Veda and James, do you like to share your screen for check? The background team, we are live in YouTube. Can you please stream in Facebook?
I think my skin is visible.
Yeah, absolutely visible, yes.
Should I share?
Yeah, please.
You
Okay.
first, sir. Dr. Ruhi.
Thank you for giving me opportunity. Visible, right?
Just wait, please.
Yeah.
Yeah, it's visible, yeah.
Yes.
Okay, fine.
Can I try to share my screen?
Sure, James, it's your turn now.
Oh, wait. There. Is it?
Yeah.
Is it
Yeah.
showing?
Visible.
This is
Nicely.
visible. Yes, yes.
Okay. Thank you.
Can I try mine?
Sure, please.
Sure.
Can you guys see it?
Yeah.
Yes.
Yeah. If anyone have any video, you can just check the video is running or not.
Oh,
I
I
don't.
actually do.
Okay.
Can I try my video on?
Sure, please.
Okay. I think it works.
Yeah, it's absolutely
Yeah,
fine. Yes.
Yeah, it's working.
This one works. Okay.
I'm seeing Dr. Digvijay, sir. Dr. Digvijay, most welcome, sir. Thank you for joining.
Yeah, thank you. I'm just attaching my presentation once.
Yeah, sure. No problem, sir. Background team.
Okay.
Yeah. Are you live in Facebook?
Hi, sir.
Hi, everyone.
Hi,
From
sir.
the
Dr.
Hello.
Edgar, how are you, sir?
I'm Dr. Ed. Hi.
Yeah.
Nice
Yeah,
to
thank-
see everyone here.
Thank you for joining, sir.
Sure,
Thank you.
sure. Thank you for the invitation.
Thank you.
So how is everyone?
Yeah, we are processing, sir.
Sure. Yeah, we're fine, sir. So it's a
and-
little bit night, right? At Philippines.
Yes, it's 10 in the
Yeah.
evening.
Yeah. So,
Yeah, it's
so,
okay.
but still, thank you. Thank you for staying with us.
Sure, sure.
Okay. Good night
It should be a
also.
very interesting discussion.
Hopefully, sir.
Yes.
Mizan sir, assalamu alaikum, sir.
I'm just trying to
Sure.
video is running or not.
হৃদয় কেমন আছো?
আসসালামু আলাইকুম স্যার, ভালো আছি স্যার, ভালো আছেন স্যার?
রুহি কেমন?
Hello, sir.
ডক্টর
Nazrul sir is with us.
স্যার আসসালামু আলাইকুম স্যার।
Walaikum assalam. Walaikum assalam. How are you all?
How are you?
Fine,
fine,
thank
sir.
you. Fine.
Everyone,
Dr. Anandita, how are you?
She is muted.
Assalamualaikum,
How
sir.
are you?
Walaikum assalam.
সালমা কেমন? ভালো?
Alhamdulillah, sir.
Dr. Vidya Anandita, you are from Indonesia?
Yes, I am.
Okay, okay.
How are you
Yeah.
today?
Yeah, fine. Where are you, in Jakarta or somewhere else?
I currently live in Jakarta, but I practice mainly in Serang, Banten. It's 2-hour drive from Jakarta.
Madam, assalamualaikum.
Okay, okay.
I am Dr. Ed from the Philippines.
Okay.
Hello.
Hi, Dr. Ed.
Welcome, welcome to the.
Thank you for the invitation.
Dr. Edgar, do you know Iloilo? Iloilo?
Oh, yes, yes. Have you been to Iloilo? That's the birthplace of my father.
Oh,
Yes, birthplace of your father?
Yes, Iloilo City. Have you been to Iloilo?
My younger brother, he married in Philippines and they reside in Iloilo.
Oh, that's very good to hear.
Yes.
So Professor Mizan is also a
Welcome,
half citizen of Philippines.
Iloilo.
Assalamualaikum, madam.
Good evening, madam.
Paul Gomez, you are from which? You are from?
I'm from Philippines. I'm from the Philippines, sir.
Dr. Gomez also from Philippines?
Yes.
We work together in the same
Yeah.
center.
Dr.
The Asian
Edgar
Eye
is my
Institute.
mentor.
Sir, we are live now.
Dr.
Thank you.
Yeah.
What about Corona situation in Philippines?
I think, Dr. Ashraf, we should be live at 8:30.
Sir, we will just live because of the technical about the technical part. But
Okay.
the final part, what will be uploaded, will be the gist part of the webinar.
Okay.
Thank you, sir.
Thank you. Dr. Fang will join, right?
Yes, sir. Dr. Fang will join soon.
আশরাফ আমার সাউন্ডটা কি শোনা যায় ঠিকমতো?
ম্যাডাম আপনাকে একদম ক্লিয়ার শোনা যাচ্ছে।
ওকে ফাইন।
আসসালামু আলাইকুম ম্যাডাম।
আসসালামু আলাইকুম। উম্মে সালমা কেমন আছো?
আলহামদুলিল্লাহ ম্যাম, আপনি কেমন আছেন ম্যাম?
আলহামদুলিল্লাহ। And my sweetheart, all the junior fellows, assalamu alaikum. How everybody are?
Alhamdulillah.
Nice to meet you.
Nice to meet you, Prof.
Okay, I'm Dr. Zakia from Bangladesh and currently working in Anwar Khan Modern Medical College as a faculty. Okay. নজরুল ভাই, মিজান ভাই।
হ্যাঁ ভাই, কেমন আছেন?
all Deshi fellows.
কেমন আছেন? আমরা তো বাংলা বললে তো ওরা তো কিছু বুঝবে না।
No, it's better not to.
It is better not to order the Bangla in the honor of them. Okay.
Sir, assalamu alaikum, sir. Munir sir is here.
হ্যাঁ মনির, কেমন আছো?
Perfectly fine.
জি ভালো আছি, আলহামদুলিল্লাহ।
We are just waiting for our chief guest.
স্যার।
Just a question, if I may ask. Our main language is English. Is that what we are following the whole time?
Yes, Dr. Edgar, the whole webinar will be conducted in English. So
Okay.
it's excellent for us. And,
Thank you.
No problem.
And anything that we need to know
স্যার, আসসালামু আলাইকুম। মুক্তাদির স্যার, আসসালামু আলাইকুম।
স্যার।
ভালো আছেন স্যার?
Muqtadi sir.
হ্যাঁ।
হ্যালো
স্যার, আসসালামু আলাইকুম স্যার, ভালো আছেন স্যার?
ওয়ালাইকুম সালাম, কেমন আছেন?
ভালো স্যার।
আসসালামু
Thank you
আলাইকুম,
sir.
স্যার।
Thank you for
Dr.
joining.
Fang, welcome.
Yeah.
How are you?
Good.
Hi,
Dr.
SK.
Fang.
Hi everyone.
Sir,
Hi
how
everyone.
are you?
Thank
Thank
you,
you for
thank you.
joining, sir.
Professor Nazrul, how are you?
Fine, thank you very much. Fine, thank you.
Sir, assalamu alaikum, sir. How are you, sir?
Fine,
Muqtadir,
fine.
sir.
Thank you, fine.
Dr.
Mizanur Rahman.
Fang. How are you, Dr. Fang?
Good. I'm good.
Okay, welcome.
Sir, we are
Thank
just
you.
waiting for Professor Abha Hussain and Professor Sharfuddin Ahmed.
Professor Abha Hussain, madam already joined. I see her name here.
Yes,
She's
madam.
already-
Madam,
Madam,
chale
Assalamu
aao.
alaikum.
Yes.
Welcome, madam. Assalamu alaikum.
Assalamu alaikum, madam.
Assalamualaikum, madam.
Good evening,
Good
Fang.
evening.
Yes, good evening.
Hi.
Muqtadir bhai.
Muqtadir bhai.
Assalamualaikum, madam.
Assalamualaikum, madam, sir.
Madam, assalamu alaikum.
Alaikum salam.
ম্যাডাম
বাকিরা-
অনেক ভালো লাগছে ম্যাডাম দেখে আপনাকে।
Oh, thank you.
Zakia must tell in English so that other faculty can understand. What you said to madam must understand by others. So you should speak English. Madam is looking so beautiful. So she told in Bangla.
I'm telling that madam is looking outstandingly beautiful.
Oh, thank you so much.
Thank you.
Our very
Dr. Fang,
much
how
valuable
are
madam.
you?
I'm
Dr. Fang?
okay. I'm okay.
Okay.
Thank
So
good to
nice
see you.
Right?
Yeah.
Nice to see you.
Yeah, good to see you.
Looking forward to see you on 14th August.
Yes.
Professor Sharfuddin joined. Welcome,
Yes.
Professor Sharfuddin.
Welcome. Good evening,
Assalamualaikum, sir.
Good
everyone.
evening. Good evening.
Assalamualaikum, sir.
Good evening.
Professor Sharfuddin, how are you?
Yes,
Professor
sir.
Muqtadir.
Yes, sir. Yes. Assalamu alaikum.
Dr. Vidya Ananda.
Yeah,
Anindita.
madam,
I
assalamu
think
alaikum.
everybody has joined.
Fang is here.
Yes,
Fang
yes,
Kong. Yes.
yes.
Good evening.
Good to see you. Good evening.
Yeah. Thank you.
Sir, assalamu alaikum, sir.
Salam.
We have 1 minute left. Madam.
Google time is 8:29.
Yes, sir.
Sharfuddin bhai, assalamu alaikum.
Salam. Mijan? Okay,
How are you? Fine.
Yeah, fine. Everyone is here.
Assalamualaikum, sir.
Yeah. Munir, thank you.
আশরাফ কেমন আছো?
Alhamdulillah, sir. ভালো আছি, sir. ভালো আছেন, sir?
Vidya Anandita.
Hi.
Yeah, hi. Thank you.
How are you?
James Paul Gomez.
Hello, sir. Good evening.
Yeah, good evening. And another foreigner from Edgar.
Yes,
Lorenberger.
Dr. Ed
Yeah.
from the Philippines.
Good evening.
Yes.
Yeah, thank you.
Good evening, everyone.
Yes. And another one is Digbijoy Singh. He's from India?
Yes, sir.
Yes, sir.
Yeah.
Yeah, good evening, sir.
Good evening.
He is the president of Indian Young Ophthalmological Society.
Yeah.
Yeah, good evening.
So just after Abha madam has joined. Madam, আমরা কি শুরু করব?
Yes. Madam is here. Madam is muted. I think you can start now as because it is 8:31.
জি। Abha madam, আমরা শুরু করব, madam?
Yes, Ashok, start.
Thank you, madam. Dear ophthalmologist, very good evening. Welcome to Bangladesh Young Ophthalmologist Society WIO International Subspecialty Webinar Series, My Glaucoma Practice. From the establishment, Bangladesh Young Ophthalmologist Society, we are trying to showcase the Bangladesh Young Ophthalmologist activities. And also, we are trying to share and learn from the international young ophthalmologists. So after the establishment of 17 September 2020, it's nearly 10 months, and this is our 32nd project and 32nd program. So I am Dr. Ashraful Haq, the President of Bangladesh Young Ophthalmologists Society. Welcome you all to today's webinar. We are very much grateful to have with us as the chair of our today's webinar, who needs no introduction, Professor Abha Hussain Madam. She is the President-elect of Asia Pacific Academy of Ophthalmology. She is the past president of SARC Academy of Ophthalmology. She is the advisor of Ophthalmological Society of Bangladesh. And most importantly, she is the chief patron of Bangladesh Young Ophthalmologist Society. We have with us our chief guest, Professor A.K.M. Muqtadir sir. He is one of the respected senior ophthalmologists in Bangladesh. He is the president of Ophthalmological Society of Bangladesh. And most importantly, he is the advisor of Bangladesh Young Ophthalmologist Society. We are very much grateful to have with us as our special guest, Professor Muhammad Sharfuddin Ahmed sir. He is the Vice Chancellor of Bangabandhu Sheikh Mujib Medical University, what is the most and highest medical university in Bangladesh. He is the past president of Ophthalmological Society of Bangladesh, and most importantly, he is the patron of Bangladesh Young Ophthalmology Society. We are very much happy and honored to have with us Dr. Sang Kyung Fang. He is the chair of Asia Pacific Academy of Ophthalmology, Young Ophthalmology Standing Committee. He is the president-elect of Asia Pacific Glaucoma Society, and he is the past president of Malaysia Society of Ophthalmology. And most importantly, Dr. Fang was with us from the very beginning of Bangladesh Young Ophthalmologist Society, and he was with us from the beginning of Asia Pacific Young Ophthalmologist Forum. Thank you, sir. Thank you for supporting us. And we have our expert panelist, Professor M. Nozrul Islam, our glaucoma mentor. He is the past president of Bangladesh Glaucoma Society. He is the chair of Scientific Committee of Bangladesh Glaucoma Society, and he is the board member of Asia Pacific Glaucoma Society. We have with us Professor M. Mizanur Rahman sir. He is the president of Bangladesh Glaucoma Society. He is the advisor of Bangladesh Young Ophthalmologist Society. We have with us Professor Zakia Sultana Shohid. She is the former Secretary General of Bangladesh Glaucoma Society. She is the Professor of Ophthalmology of Anwar Khan Modern Medical College Hospital. We are very happy to have with us Dr. Edgar Luenberger from Philippines. He is the consultant of Asian Eye Institute. We have with us Professor Iftekhar Muhammad Munir. He is the professor and head of the Department of National University of Ophthalmology and Institute, Dhaka, Bangladesh, and he is the treasurer of Bangladesh Glaucoma Society. And we have with us the speakers from representative from the Young Ophthalmology Society of India. We have with us the Philippine Network of Young Ophthalmologists representative and Young Ophthalmologist Indonesian Ophthalmologist Association, and our very own the speakers from Bangladesh Young Ophthalmology Society. We will introduce our speaker at the talk time, but we are very much delighted to have with us Dr. Digvijay Singh. He is the president of Young Ophthalmology Society of India, and Yoshi has been very collaborative and supportive for BIOS from the inception of BIOS. And thank you, Dr. Digvijay. Thank you for joining with us. And we will now start our webinar with the permission and welcome address by our chair, Professor Abha Hussain Madam. Madam, please unmute yourself.
Thank you, Ashraf. It is a great pleasure and a real privilege for me to be here today and able to welcome you, the honorable chief guest, our beloved President, Ophthalmological Society of Bangladesh, Professor A.K.M. Muqtadir, our special guest, Professor Muhammad Sharfuddin Ahmed. We are very proud that he is the Vice Chancellor of Bangabandhu Sheikh Mujib Medical University, and he is the first ever ophthalmologist being this post as a Vice Chancellor. So we are very proud of him. And we have with us Dr. Fang. Already you know that he's the chairman of Young Ophthalmology Society, not society, but APO Standing Committee. And the honorable panelist, Professor Nozrul Islam, is the renowned glaucoma specialist of Bangladesh and also beyond, that is Asia Pacific region. And he always keen interest to attend all the Congress, Asia Pacific, American Academy, and all. So he's one of the panelists, and the other panelist, Professor Mohammad Mizanur Rahman, is also very sound surgeon, very keen surgeon, and Professor Jakia Sultana. I'm really very happy to see her here, as because women are nowadays in Bangladesh growing in the highest post. And when I see all in that post, I am really so happy to see Professor Jakia is one of my dear students. And the other, Dr. Edgar Leuenberger, I'm so happy to see you here. And we will hear from you, the panelist panel, what you say, and that will be very much helpful for us also. And Dr. Iftekhar Munir. Dr. Iftekhar Munir is the glaucoma, he's not only glaucoma specialist, but he is in the National Institute of Ophthalmology as a glaucoma professor there. And glaucoma subspecialty also, he started there very nicely. So all these are the panelists. And also I would like to welcome the speaker, Dr. Umme Salma Akbor, Dr. Budea Anandita from Indonesia, right? Very nice to see you. And Dr. Ruhi Mannan, she's also growing up. And Dr. James Paul Gomez, Dr. Bipul Kumar Sarkar, Dr. Digvijay Singh from India, and our moderator, Dr. Ashraful Haq, is the president of this young Bangladesh Young Ophthalmology Society. So with these few words, I would like to welcome you all once again, and let us start our program. Thank you.
Thank you, Professor Abha Madam. You are always a support and pillar of our strength. Now I would like to invite our special guest and panelist, Dr. Fang Seng Kyung. Dr. S.K. Fang, he is the chair of Asia Pacific Ophthalmology Young Ophthalmology Standing Committee, and most importantly, the concept of the society in every country develops when we are becoming the member of the APAC YO. And Dr. Fang, he is always our guardian, and I would like to invite Dr. Fang for his special guest speech and what is his advice for our young ophthalmologists. Dr. Fang, sir.
Thank you, Ashraful. You can hear me?
Yes, sir. Yes.
Yeah, I would like to thank the Bangladesh Young Ophthalmologists Society for inviting me. It's good to see our friends here again, especially Professor Awa Hussein, Professor Nasrul Islam, Professor Mizano, Edgar, Professor Shafuddin, Professor Muqtadir. It's good to see all of you and all the YO represented here as well. I'm given about 4 minutes, so I would like to just share a bit on the YO activities in the Asia Pacific Academy of Ophthalmology. If I can share my screen. You all can see my slides, huh?
Yes, sir.
Yes. Okay. I think most of you know our activities during the APAO Congress. The YOs now have a lounge. They have a YO ribbon. We also have social activities, including the YO night games, YO symposium, and we collaborate with the LDP committee. And the newest activities, actually, unfortunately, because we cannot meet physically, hopefully by 2023, we can have travel grants for YO attending the APAO conference hopefully from 2023 onwards. And also we have now YO best papers and presentation. Because of the pandemic, we do communicate with each other. We have a very active WhatsApp group, and I think this seminar is also broadcasted in our WhatsApp group, and we do have a Facebook page and an Instagram page, which I will newsletters. We're going to plan to have quarterly newsletters, and we also help member country to set up YO chapters. And you can see Bangladesh Young Ophthalmology Society is one of them. We do have now also Philippine network of young ophthalmologists, which is represented here by Dr. James Gomez. The Indonesian YO Pedami, represented by Dr. Widya. We also set up Malaysian Young Ophthalmology Society, and also recently Chinese Taipei has set up their YO activities, YO society. We now have an official logo thanks to the Philippine YO, Dr. Che Tanwako and Jubaida Aquino for their help in this in designing this logo. And we do have now 4 subcommittees formed for advocacy and education to share about fellowship, scholarship, and travel grants. As I mentioned earlier, we have a Facebook page sharing surgical videos, case discussion, and from here, we also now going to award Best Video Award during the APAO in 2021. As I mentioned, we produce quarterly newsletters. We have an Instagram account, and the top Instagram influencer will also get a award during the 2021 APAO virtual meeting. And we do have also a mentorship subcommittee to help the juniors link with the seniors and mentor and mentee program. And finally, this is something new. We have not announced this yet, but we are going to collaborate with ZEISS to have a Rising Star program, which is an 18 months program. And this 100 candidates will be selected by the APAO-YO committee, and they will be attending monthly online classes to teach them on clinical skills, soft skills such as communication, on business, on professional development. And the top 5 candidates will be selected and will be given award to attend a face-to-face meeting, hopefully by 2023. And lastly, because I'm the Asia Pacific Glaucoma Society Chair President-elect, I would like to announce that we would have our 6th APGC next year, hopefully if we can face-to-face, if not hybrid, on 5th to 7th August 2022. Thank you, and I will pass this time back to Ashraful.
Thank you, sir. Thank you, Dr. Fang, for your valuable speech. Now I would like to invite our patron, our leader, our guide, Professor Muhammad Sharfuddin Ahmed sir, to say and advise and say his valuable speech in this webinar.
Thank you, Dr. Ashraf, our beloved chairperson, our strongest woman of the world, Professor Abha Hussain, President-elect of APAO, who is now chairing this session. First of all, I show my deep respect to him. And along with it, our chief guest, Professor A.K. M. Muqtadir, our President of Ophthalmological Society of Bangladesh, Dr. Fang Seng, my old friend in APA for a long period, who is with us from Malaysia, and also Dr. Edgar from Philippines, and all the panelists from different countries, including Bangladesh, Indonesia, India, and all the countries who are presenting today. I don't want to spare much more time by saying your names here, as because our panelists, Professor Nozul and others are also here with Mizanur Rahman. I welcome all of you. I want to say that the irreversible blinding disease glaucoma, my glaucoma practice, which you have selected today, I think this is a very important topic. And we are very unlucky because of Corona. We could not attend the APA Congress in last year in Malaysia. Still, we are thinking that in 2022 or 2023, we will be able to see you all physically, even though we have from Indonesia, we are from Malaysia, but now our space, we are sitting here in a very small space. So even though we are from long period, we are sitting here together, and hope this type of webinar is very much necessary for storming our brain. And the latest treatment, latest practicing pattern will be helpful for our young ophthalmologists and young glaucoma specialists like Ruhi Mannan, Salma, and also our Bidda Nindita from Indonesia, and also James Paul, and also Digvijay Singh. All are working for a long period with this Bangladesh like young ophthalmologists and young ophthalmologist committee of Asia Pacific Academy of Ophthalmology, who have already started their Rising Star program. I hope this Bangladeshi and other countries, they will participate, and 100 candidates will be there. I hope our young ophthalmologists from our country and other countries, they will also take part, and they will be able to be benefited from this type of program. And newsletter, travel grant, everything which are being given by APAO, that is very much helpful for our young ophthalmologists. I hope this type of webinar will be very successful one. Even though if I would be able to stay with you for a long period, I would be benefited. But I have another webinar with postgraduate education after a few minutes. So I will join there. I hope physically we will see in your countries later on. And I invite all of you to my country, to my university, Bangabandhu Sheikh Mujib Medical University. If you come, I will welcome all of you with these few words. Thank you very much for patient sharing. Thank you for inviting me to this excellent webinar. Thank you very much.
Thank you, Professor Mohammad Sharfuddin Ahmed, sir. Your presence always inspires us. Thank you, sir. Now, I would like to invite the chief guest of today's webinar, our respected ophthalmologist and our guardian, the President of Ophthalmological Society of Bangladesh, Professor A.K.M. Muqtadir, sir, for his speech. Sir, please. Sir, please unmute yourself.
Unmute. Please unmute.
Congratulations to everybody. Assalamu alaikum. I am very happy to know from Ashraful Haq about the webinar, my glaucoma practice, because it is a very important subject. I am happy in that sense that they have selected a good subject, and under the dynamic leadership of Dr. Ashraful Haq, Bangladesh Young Ophthalmology Society is already going to going to organize a beautiful seminar or webinar. Glaucoma is I give thanks to the chairperson, Professor Abha Hussain, my younger sister from Bangladesh, Professor Sharfuddin Ahmed, special guest, and panelist, Dr. Sheng Kiong Fang from Malaysia. And also, I give thanks to panelists and speakers. The subject is very important, because if untreated, patient becomes blind. It is a blinding disease. There are few blinding diseases in ophthalmology, and glaucoma is one of them. I always say I am 74. In 1977, while I started ophthalmology, there were only pseudostonometer, still pseudostonometer is used. Pseudostonometer, direct ophthalmoscope, but with less illumination. In that was a bulb system, not the illumination was not good. And many of the institutions were there was no street lamp even. And somebody, senior professors have indirect ophthalmoscope, some, very few, senior ophthalmologists, very few indirect ophthalmoscope and Bock lens. Now the scenario is changed. As the cataract surgery is changed, glaucoma treatment is lot of change. I always say my Professor Shamsuddin Ahmed FRCS, he is the professor of Professor Abahushan also. If there was any mechanism to come from the barrier, very buried, if he got the life, again he would die after seeing the improvement, so much improvement in ophthalmology. In our country, there are improvement in two subjects, very improvement. One is ophthalmology, another is cardiology. I have done my stenting in Bangladesh. I have done phaco right eye in Bangladesh and left eye in Bangladesh. And very few goes abroad now. This is a very encouraging news for us. Now, many tools has been discovered for early detection of the glaucoma. Early detection of glaucoma. A time was 77, 78, 79, 90, 80. Patient would come, because I'm a student of Mymensingh Medical College. Professor Abba is also professor of Mymensingh Medical College. It is far away from Dhaka, and patient would come from village. They do not go to the doctors until and unless they are blind or their vision is too much less. Then it is obvious that it is a case of glaucoma only by street lamp, only by pseudostonometer. Now, many things. I would say my student, at least in every patient, you do two things. See the IOP, whatever the patient number is in your chamber or in the hospital, see the IOP and see the fundus disc. Now it is my practice also. I always for my practice life, I see all the patient IOP and fundus. And I have a village hospital in the village where I serve for 2 days. There are many doctors there, 2 days in a week. There I have instructed my doctors. You have to, whatever the patient, 300, 400, you have to see all the patient IOP. If they are corneal also see by NCT, you will get many. And their patient is quite, vision is less, IOP is high. Patient does not know about the glaucoma, doctor does not know about glaucoma until and unless he is seeing the IOP. So it is a very important topic, and it will be discussed. Bangladesh Young Ophthalmology Society, I give thanks to Ashabul Haq and the society members, they are arranging beautiful webinar or seminars, this type of seminars at regular intervals. Today you are a young person. I am old. Old, don't say old haggard. Old. I was also at time, I was also young, very strong muscle, but muscle now has become less. So I cannot invent now. My brain will not allow too much because it is now due to aging process, it is degenerating. No degeneration. And your brain is fresh, no degeneration, and you will be able to invent and able to give new things to the society. And this is the platform where you can contribute to the nation. And one day you will be also old, but your work will remain. Your work will remain. So that is a pleasure. A time will come when you will be able to say, I have done this and this, this and this, this and this. I have done, as a freedom fighter, I have done many things in the village, and the Government of People's Republic of Bangladesh, Honorable Prime Minister has honored me by giving the Independence Award for this rendering service for 45 years. Nothing goes in vain. So your work will not go in vain. Go ahead, and you will get a result very soon, inshallah. I congratulate also the panelists, Professor M. Nazrul Islam, Professor Mizanur Rahman, both from Bangladesh, Dr. Edgar Leuenberger from Philippines, Professor Itakar Munir, MD Munir, Bangladesh, Professor Zakia Sultana, Shahid, Bangladesh. And I also congratulate because they will contribute. Learning is a continuous process. Still I learn. Why I sit here? Learn. New things are coming, and we are learning. All persons are learning from you. A time was there when we seniors taught the students and make them doctors. Now the time when the senior most persons are learning from the youngsters. And the speakers, Dr. Salma Akbar, Dr. Vidya Anandita from Indonesia, Dr. Ruhi Manan, Bangladesh, Dr. James Paul Gomez from Philippines, Dr. Bipul Kumar Sarkar, Bangladesh, Dr. Des Vijay Singh from India. I think we learn many things from them. I have taken a little bit time, but the things I have said, it is very important because it is a very important substance. If it is maldiagnosed or undiagnosed, then the patient will be blind. In our time, there was only, you will be astonished, there was only one medicine for glaucoma, pilocarpine, only pilocarpine. Then came in 1982, probably in our country, came timolol maleate. But the operation we are doing for glaucoma from that time, a trabeculectomy. Trabeculectomy, I think, if I am not wrong, still stands for glaucoma surgery. Other things have added for improving. You will discuss. And I don't want to take more time. Thanks to all of you for arranging a beautiful webinar. Thank you very much. Wish you good luck. Thank you all. Thank you very much.
Thank you, sir. Thank you, sir. So we hope with your leadership, Ophthalmological Society of Bangladesh will always support us. Now we will move forward to the talks, what we are waiting for. So I would like to invite Dr. James Paul
Thank you, madam.
Gomez, who is the
Ashraf,
representative. Sir.
Ashraf, I'm now to leave for another webinar. Thanks to everyone, including Professor Abha Hussain, Dr. Fang, Dr. Muqtadir, Professor Nozul, everyone. Thank you very much. I will see you later on. Thank you.
Thank you, sir. Thank you.
Bye, sir.
Thank you.
Okay,
Thank you,
bye.
you.
Bye.
Bye.
So, dear audience, I'd like to request Dr. James Paul Gomez. He is the representative of Philippine Network of Young Ophthalmologists, and he is working as junior consultant at Asian Eye Institute. He will be presenting on a very interesting topic, the new vascular glaucoma after phacoemulsification. Dr. James, please share your screen.
Okay, let me share my screen first. Can you see my slides, sir?
Yes. You're
Okay.
visible and you're audible.
Okay. So, good evening, everyone. It is a pleasure to speak in front of you tonight. My glaucoma practice so far has been fulfilling, but not without its challenges. Perhaps the most thought-provoking of which is when a patient of mine developed neovascular glaucoma after phacoemulsification. This happened to a 74-year-old male who complained of blurred vision for the left eye. He had multiple comorbidities. His preoperative visual acuity was only 20/80 with normal IOP. Angles were open. The disc was normal. His lens was cataractous. His retina and macular OCT did not exhibit signs of diabetic complications. But after an uneventful phacoemulsification, his vision improved to 20/20 with IOPs below 20. He was happy post-operatively until the 2-month mark when he noted a gradual blurred vision and general eye discomfort for the left eye, which persisted for a week before he consulted. When I saw him, his vision has already deteriorated to hand movement with an intraocular pressure of 50. The cornea was edematous, the anterior chamber was formed, and the intraocular lens was in place. After an initial bout of medications, the IOP went down to 20. We found iris vessels along his pupillary margin. Peripheral anterior synechiae were found scattered across all quadrants. The signs pointed to a diagnosis of neovascular glaucoma in the beginning angle closure stage. It was an unexpected outcome, and as the patient was distraught, I tried my best to pacify him and explain why we think it occurred. NVG is mainly caused by diabetic retinopathy, CRVO or central retinal vein occlusion, and ocular ischemic syndrome. Diabetic retinopathy is usually bilateral, while CRVO and OIS are unilateral. Additional risk factors for OIS include a male sex, advanced age, systemic diseases, smoking, and a delay in seeking medical consults, all of which were ticked by the patient. The retinal veins are dilated but not tortuous in OIS. Hemorrhages and hard exudates may vary between the 3, and the optic disc may appear normal in OIS. An angiogram will reveal a prolonged AV filling time in both CRVO and OIS. And one distinguishing factor for OIS is that the choroidal filling will be delayed and patchy compared to the other two. And here's the fundus photo of our patient. Notice that there's attenuation of arteries and the veins were dilated but not tortuous. On fluorescent angiogram, it showed that at 25 seconds, choroidal fluorescence was still not complete with a patchy appearance. And at 31 seconds, there is still a delayed filling of both arteries and veins, and complete vessel filling was only shown in subsequent shots. The retinal findings as well as the risk profile of the patient pointed to a diagnosis of neovascular glaucoma secondary to OIS. Recall that the carotid artery bifurcates into the internal and external carotid arteries, and the ICA is the one that gives rise to the ophthalmic artery. OIS occurs if there is stenosis and poor collateral circulation between these arteries. And because of carotid stenosis, there's global ischemia affecting both the anterior and posterior segments, and ischemic tissues may release angiogenic substances, causing new vessel formation and eventually neovascular glaucoma. Anterior segment ischemia may present as iris atrophy and neovascularizations, and an iris angiogram would show a slow and patchy filling of iris vessels with staining in areas of neovascularization, and the IOP can also be increased. The appearance of retinal veins in an OIS match that of our case, And additionally, OIS will present with decreased retinal artery perfusion and a cherry red spot in some cases. An ischemic retina should be addressed with laser and anti-VEGF injection, and uncontrolled IOP can be managed with medications and surgery. The patient must also be referred for a complete medical workup and carotid surgery if necessary. So, with OIS in mind, the eye of our patient was promptly injected with aflibercept, and 2 weeks after the injection, the iris and neovascularizations had visibly regressed. However, the PAS and the visual acuity remained at status quo. So a carotid Doppler scan was done to confirm carotid stenosis. It showed that there was a 70% stenosis in the left carotid artery with decreased blood flow. And MRI angiography was also ordered, and this was when another diagnostic dilemma came to be. The MRA showed that the carotid plaque was MIA. It was missing in the artery. There was normal caliber of the carotids without any evidence of stenosis, aneurysm, and malformation. So where did the stenosis go? Or was it not present in the first place? At his last follow-up with us, the vision had slightly improved to counting fingers. But after the pandemic started, we have not seen the patient since. So this case raises two diagnostic dilemmas. If it was not OIS, what triggered anterior segment neovascularization in the first place? Was it diabetes or another type of vascular occlusion? And can carotid stenosis leading to OIS be transient? In my practice, this is the first ever case that developed into NVG post-operatively. A retrospective study observed that such a phenomenon in diabetic patients can occur, and NVG developed in surgeries where the posterior capsule was violated. They theorized that its removal allowed for angiogenic substances from an ischemic retina to escape into the anterior segment, forming new vessels. But what about phacoemulsification? In another cohort study on diabetic patients, they showed that 32% of eyes who underwent phacoemulsification progressed in just a span of 12 months. As much as 41% progressed by 3 stages. But the study did not report any eye who developed NVG, implying that such an occurrence is rare. And so, could our case have been caused by a localized vascular occlusion like CRAO then? These photos are of patients who developed central retinal artery occlusion after an uneventful phacoemulsification. Both cases had a peribilbar anesthesia injection prior to surgery. And its use can cause vasoconstriction, transient IOP rise, and iatrogenic injury leading to CRAO. But this does not apply to our case as only topical and intravenous anesthetics were used. Now let's address the second issue of this case. Carotid stenosis can lead to occlusive disease by embolism and poor perfusion. But there is evidence that carotid stenosis can be transient. In this picture, there's severe atherosclerosis in the carotid artery, but notice that there are lumens of recanalization, implying that plaques can resolve. And I also found a similar case wherein a 54-year-old male who presented with massive ischemic stroke with loss of vision for the right eye, his initial CT scan showed that there was near complete occlusion of the internal carotid artery. But after 2 months, a repeat scan showed that there was recanalization. However, he did not regain vision. These show that carotid stenosis can be fleeting, but its effects can indeed be permanent. We may never be able to determine with full certainty why NVG developed in our case. It is possible. So patients with identifiable risk factors should have more stringent management for their comorbidities and be referred for a complete evaluation. Also, advise patients to seek consult immediately if anything is out of place. But perhaps the most vital lesson that I learned from this case is that the way you communicate will always affect how a patient will react to an ordeal. My patient and I were disappointed with the outcome, but I tried to present myself as a patient advocate, pouring all my concern to his needs. I made an active effort to address all of his queries, speaking in a terminology that he would understand. It's in these circumstances that he realized that the science of medicine needs to be supplemented by the art of communication. I would like to acknowledge Dr. Leuenberger, Dr. Velosa, and Dr. Burbea for helping me manage this case, and for my radio friends, Dr. Tagal and Esquivel Mendoza, for their help in this case. Thank you very much.
Thank you, Dr. James, for a nice presentation. Now I would like to invite Dr. Edgar Leuenberger for his valuable panelist comment. So please unmute yourself.
Okay, thank you for the invitation. I'm very grateful that I'm participating, especially with one of our most outstanding fellows from our institution, Dr. James Gomez. I have been consulted with this case since the start that Dr. Gomez had encountered this problem. And I think more than the technical part of the issue here is to really how to maintain the trust of the patient and how to encourage the patient to just keep on following up. You know, in our practice of glaucoma, chair time is very important. And what's more important is really chair time pre-op than post-op. So patients, no matter how routine the surgeries are, such as this case, you have to identify that there are a number of comorbidities that may present surprises after the surgery. And this has to be dealt with in detail and extensively discussed with the patient. In fact, the case of Dr. Gomez is the very first case that I have encountered in my 20 years of practice. And it really was an eye-opener for me that you cannot take any patient, no matter how simple the case would be, cannot take the patient's case for granted. And given all the comorbidities, I would have probably spent maybe an hour with this patient and discussing everything. Unfortunately, the downside, because it really is a balance, if you spend so much time, there's a risk that you will scare the patient away. And some patients really say, you know, I don't need to know all of these things, just give my vision back. And, you know, it's important to realize that you have to tell the patient what they need to know, not the patient, not what the patient wants to know. And so just being very forthright and honest with this patient would probably ease the burden of encountering this problem post-op. Now, another issue here that I would discuss with the patient is the possibility of doing surgery on the other eye. And that can be a bit of a challenge because given the patient's experience, there's a certain degree of phobia, and patients would rather not proceed with the surgery on the other eye given the not so good experience with the first eye. And that can be a challenge. And I think what's more important is not only you as an attending doctor, but all the staff involved are aware that this patient has not encountered a not so good experience, and they have to be on board in encouraging the patient to understand that this is something that is beyond our control and that we did everything. More and more patients are now educated because of the internet. But you know, we tell patients that we cannot give 100% guarantee that everything will go well. What I tell my patient is that we give 100% guarantee that we will take good care of them. That is a more realistic expectation than a patient who would come to us and say, okay, what if I don't get 100% guarantee, I would not proceed with the surgery. It is not a realistic expectation. So I guess in this case, I would summarize by saying that we do everything to minimize the risk. And if the unfortunate event happens, then we have to prepare the patient with realistic expectations. And I thank Dr. James Gomez for sharing the case with me because I really learned a lot in this patient.
Thank you very much. Thank you, sir. Thank you, our speaker and the panelist from Philippines. The Philippine Network of Young Ophthalmologists, from the very beginning of Bangladesh Young Ophthalmology Society, we have the collaboration. We had the previous webinars and we have a very good friendship. And I would like to show my gratitude for this to Dr. Charis Sanchez Tanlepko and Dr. Jubaida Aquino. Thank you very much for being with us. Now we will move to our second presentation. Dr. Salma Akbar. She is the executive member of Bangladesh Young Ophthalmology Society. She is now presently working at Chittagong Eye Infirmary and Training Complex, and she is the coordinator in charge of our BIOS most engaging project, Bio Capture. Dr. Salma will be talking on Ahmed glaucoma valve implantation in pediatric cataract. Dr. Salma, please share your screen.
Is my screen visible?
Yes.
Good evening. I am Dr. Salma Akbar from Chittagong Eye Infirmary and Training Complex, and I welcome you to my presentation on Ahmed valve implantation in pseudophakic pediatric glaucoma. A 12-year-old boy hailing from Cox's Bazar came to the glaucoma clinic of Chittagong Eye Infirmary and Training Complex with secondary glaucoma resistant to pharmacological treatment in his right eye. 5 years back, he underwent cataract extraction with implantation of posterior chamber intraocular lens, and he also gave a history of trauma to the similar eye 5 years ago. On ocular examination, his best corrected visual acuity in the right eye was 660 and 6.6 in the left eye. His intraocular pressure was 50 millimeter of mercury in the right eye and 16 millimeter of mercury in the left eye. His color fundus photograph showed a cup disc ratio of 0.9:1 in the right eye and a normal disc in the left eye. He was treated with a combination of brimonidine tartrate and timolol maleate eye drop twice daily and tefluprost eye drop once at night. On his subsequent follow-up, his visual acuity remained unchanged and his intraocular pressure in the right eye was 40 millimeter of mercury. We added brinzolamide eye drop thrice daily to his previous medication and took up this case for Ahmed valve implantation under general anesthesia. After proper counseling, the case was performed under general anesthesia by my mentor, Dr. Shams Muhammad Nomar. Initially, a corneal traction suture was placed, followed by a conjunctival peritomy. The marking for the placement of implant was done 8 millimeter behind the limbus. The Ahmed valve was primed before use. It was irrigated with 2 ml of balanced saline solution. The plate was then secured to the superficial sclera with 2 interrupted non-absorbable 9-0 nylon sutures. These are the 2 sutures being given. The tube was then trimmed to enter 1 to 3 millimeter beyond the posterior surgical limbus. A 23-gauge needle was used to enter the posterior surgical limbus. We then used a smooth forceps to push the tube through the tract into the anterior chamber. The tube was then placed over the sclera with 2 non-absorbable 9-0 nylon sutures. This is a patch graft. In order to avoid the erosion of the tube, processed pericardium, that is tutoplast, was sutured over the tube. This is the tutoplast, which was sutured over the tube. We used 4 interrupted sutures. The conjunctival closure was done with 80 vicryl sutures. Subconjunctival injection of antibiotics and steroids were used at the end of the surgery, and thus the surgery was concluded. These are the postoperative pictures of the implant on the first operative day, 1 week following the surgery, and a month following the implantation. The best corrected visual acuity was 624, and the intraocular pressure was 12 millimeter of mercury in the operated eye, which was maintained for a year-long follow-up. As we all know, the Ahmed glaucoma valve implant is a valve polypropylene tube implant which is designed to provide resistance to aqueous outflow and decrease the chances of severe postoperative hypertonic. Management of pediatric glaucoma, especially the traumatic glaucoma, does not respond satisfactorily to medical treatment or filtering surgery. The Ahmed glaucoma valve can be used in aphakic or pseudophakic glaucoma, neovascular glaucoma, traumatic and refractory glaucoma, no response to other glaucoma surgery, glaucoma associated with uveitis, Sturge-Weber syndrome, and following penetrating keratoplasty. The management of refractory glaucomas has considerably improved over the last 2 decades with advances in glaucoma drainage implant surgery. These devices allow a large surface area reservoir for the drainage of the aqueous humor and provides a mechanism whereby the aqueous humor may bypass the excessive scar tissue formation. The Ahmed valve works by creating an alternate pathway for aqueous outflow by channeling the aqueous from the anterior chamber through a tube towards the subconjunctival or the suprachoroidal space, where it is absorbed into the systemic circulation by diffusion and through the scleral veins. Coleman reported a success rate of drainage implants in children varying from 44 to 95%. Coleman et al. Also reported an overall success rate of 77% and 60.6%. Englund et al. Reported a success rate of 90.6% and 58.3% at 12 and 24 months respectively. And Jodar et al. Reported an overall success rate of 70% to 63% at 12 and 24 months respectively in pediatric patients with Ahmed glaucoma valve implants. Hence, our case confirmed that Ahmed glaucoma valve may be safe and effective treatment for pseudophakic refractory glaucoma in children despite its post-operative complications. This procedure may be used to treat the complicated glaucoma in eyes with previous failed filtering surgeries. With this, I would like to convey my gratitude for giving me this opportunity today. As Robert Frost said, the woods are lovely, dark and deep, but I have promises to keep and miles to go before I sleep and miles to go before I sleep. Truly, I also have a long way and a lot to learn in this field. Thank you. Stay safe, stay healthy.
Thank you, Dr. Salma. It was an excellent presentation. Now, I would like to invite our teacher, our glaucoma mentor, Professor M. Nazrul Islam sir, for his expert comment.
Thank you, Dr. Shraf. It was a beautiful presentation. And I am really very great pleasure for me to be here in the Young Ophthalmologist webinar, and where my teacher, my mentor, Professor Abha Hussain is the chairman. And she is our inspiration. Wherever she is, we really get inspiration. Thank you, madam. And also our chief guest, OSB President, Professor Muqtadir sir, our special guest, Professor Sharfuddin, already logged out. Thank him. And another special guest, Professor Seng Kyung Fang, my good friend, and really thank you so much for coming. And especially we are thankful to him also because he has a lot of support to Bangladesh Glaucoma Society also. Thank you for that from the APGS. And you know that he is the president-elect of the Asia Pacific Glaucoma Society. And my fellow panelists, speakers, and moderator. Really, I was amazed to see the beautiful presentation, wonderful presentation by Dr. Salma Akbar, and especially her presentation style, really superb. Thank you so much. And of course, she has definitely shown us a complete case of a child, pseudophakic glaucoma, and which is really a refractory glaucoma. So definitely, it is of course acceptable to go directly to a glaucoma drainage devices, because we know that these are the cases where the filtration surgery failure is really high. So definitely, I agree that valve implant, especially valve, not the non-valve one for the children, is better. But of course, as the children is young, this patient will remain many years to life. So definitely, if we have the facility to the internal like mix, like the GAT or the internal 360-degree trabeculotomy, that can be a choice also, this kind of patient. Because if we can do a ab internal trabeculotomy 360-degree, that also has similar result like the filtration surgery. And that is a choice for us, because these children, we know after 5 to 6 to 10 years, he will need another surgery. So then definitely the valve will be there. So this is also choice for us. And I have seen that you are used the FP7, the adult model. Yes, that is the right choice, because I see many people use the pediatric FP8, but actually that is not the right way, because most of the time in pediatric glaucoma cases, we find ophthalmos. The eyes are large actually. So when there is a larger eye, not use of a smaller size device is not important. So definitely you can use the larger size, because we know that larger plate gives better result of IOP reduction. That's very important. So you have done a beautiful surgery. I think nothing to add too much, but few things I would add here, that in the children must give the donor patch. Sometimes we do the surgery with the patient's own scleral flap, but this is the time in children or in high myopic cases, definitely have done the right thing to give the patch. It's very important. And also I noticed that your tube in the eye is about 2.5 millimeter. That's also very good, because in the children, if we make a smaller size tube like 1.5, it can have tube retraction. When the tube is aging, it can have tube retraction. So that is another good tips, that you should put the tube as much as possible towards the iris, not towards the cornea. That is very important. Towards the iris, and it makes the tube at least 2.5 millimeter, so that after retraction it will be at least 1 millimeter, 1.5 millimeter. That is very, very important. And another thing, recently I'm using the Olozen along with in children, because the children, the success is not that much like the adult also in the refractory glaucoma. So in these cases, there is some different studies also recently published that it is giving better outcome. If you can put the Olozen over the plate of the valve and put in the into muscle, that also gives better result. That is another choice, of course. And lastly, I would say that I know Dr. Fang know very well Paul Chiu, who is the owner of the micropulse laser. The once we talked to him, he said we are giving a lot of study in children, the micropulse in children. So he says we are getting the positive result. The positively we can also use the micropulse in children. And if the micropulse comes, our job will be very easy, because the micropulse can be used even in children. So I think that is to be keep in mind. If the investigation and the research shows it is safe, definitely we'll be able to use it. And I think not much more. The presentation was very good. And of course, I agree with most of the points you already presented for the glaucoma. One thing I will say that I will be reserved about the brimonidine. You have shown that you have treated the baby with brimonidine and timolol. You know that we'll try not to give brimonidine up to 12 years, though the baby is 12 years. So in that case, it's marginal, but our routine practice is more than 12 years. So I'm really not very happy about giving the brimonidine in children. That is my suggestion. So thank you very much for your beautiful presentation. Thank you.
Thank you, Professor.
Thank you, sir. Thank you, sir.
Thank you, sir, for your valuable comment. Now, We have for the first time representation from the Young Ophthalmologist of Indonesian Ophthalmologist Society Association, Dr. Vidya Anandita. Dr. Vidya Anandita, we know each other from Asia Pacific Young Ophthalmologist Forum from the beginning. After that, we formed BIOS. And Dr. Vidya, she is the representative of Asia Pacific Young Ophthalmologist from Indonesia and also the Asia Pacific Young Ophthalmologist Facebook and social media group. So Dr. Vidya will presenting a very interesting topics, the new faces of many faces of uveitic glaucoma. Dr. Vidya, please share your screen.
Okay, let me share my screen. Okay. Good evening to all panelists and participants today. My name is Vidya Anandita. I'm from the Young Ophthalmologists Indonesia Ophthalmologist Association, and I currently work in Ahmad Wari Eye Hospital in Serang, Indonesia. And today I'm going to talk about the many phases of uveitic glaucoma. And thank you again for BYOS for inviting me today. Okay, uveitic glaucoma remains one of the most serious complications of intraocular inflammation and could happen to 10 to 46% of uveitic patients. The rise IOP can be attributed both to inflammation and corticosteroid use, and it can present both as open and closed angle glaucoma. This is a case of patient of a male, 49 years old. But before, I want to give you some background. So I practice mainly in Serang, Banten, which is the yellow dot, and the patient live in Merak, Banten, which is the purple dot. And he would have to travel by bus, by 3 different buses in 3 hours just to get to me. And before, he have to go to Bandung, which is 400, 500 kilometers from where he was. So during this COVID pandemic, he wasn't able to keep his appointment for the last 9 months before he met me. So when he met me, he already have blurry vision in both eyes for 1 month. He will have history of uveitis for the past 5 years and has been diagnosed with glaucoma for the past 2 years. He has no prior history of surgery or laser, no history of trauma, and have been using hydrosteroids multiple times. And he doesn't know what types of uveitis he's having, but I noticed that he has a hypopigmentation lesion under his right hand and also history of tinnitus. So this is probably a Fokai Nagiharada disease case. And currently, when he met me, he was already on acetazolamide and tamolol for 1 week. So this is the eye. The right eye visual acuity was hand movement. IOP was 40. The cornea was edematous. And what was amazing about this eye was that the anterior chamber was flat. There was no anterior chamber at all. There was membrane on the pupil, but we can also see that there was a deep posterior chamber with hazy lens. And on the left eye, we saw an eye with iris Bombay, but good IOP with 15.6. But remember that this patient is already on acetazolamide. And the visual acuity was only 1 meter finger counting. No cells and flare with also hazy lens and membrane. So we assessed this patient with uveitic glaucoma due to Fokai Nagiharada. And at the time of the presentation, we do LPI on the left eye. And then we plan to do trabeculectomy with membranectomy and sanicolysis and AC reformation on the right eye the next week. Okay, this is the video of the AC reformation. What's interesting about this particular patient is when you do AC reformation, you usually do it with viscoelastic. But if I just did it on top of the pressure on the posterior chamber, then I would have very high IOP. So I make a tunnel with viscoelastic, and then I make a puncture on the membrane and slowly release tension from the posterior chamber while reforming the anterior chamber. And then afterwards, I do sanicolysis, especially on the angles, and we do membranectomy with help of Utrata forceps. So following that operation, the next day, of course, the patient was put on high-dose steroid with methylprednisolone. The visual acuity improved drastically to 20/160. I remember it clearly, as the patient could walk, get into my practice, walking happily before he wasn't able to. So it was a really great day for the both of us. IOP was good, but I noticed that the PI closed in the left eye, and then 1 week after, visual acuity remained the same, but the left eye IOP increased to 44.8. But we also have good news because on that day we do endothelial cell count, and it was actually 2,300 for the right eye. So the cornea was working and the endothel was actually working, what was before like a very edematous cornea. So we planned to do surgical PI, but then we lost the patient for 2 weeks because he was hospitalized due to systemic condition. And then when he was hospitalized, the internist stopped the methylprednisolone, and then the patient got membrane formation on his right eye. So the visual acuity goes back to hand movement on both eyes. We still did surgical PI on that eye. And then afterwards, the IOP was great without any glaucoma medication, but the patient has very poor quality of life due to his visual acuity. So then we were thinking about doing phaco on this patient, especially on the left eye, even though we're not quite sure about the inflammation control. But I think at that point, the patient really need something to improve the quality of life. So we did it. This was the phaco video. It was actually quite typical for patient with uveitis and membrane. We need to use the help of iris retractor, but other than that, things went well and things went smoothly. After phaco, then visual acuity improved to 20/160 on the left eye, and we can see sunset glow appearance. It's actually the first time we can assess the findings of this patient. It was quite inflamed with cells +3, but it was under control. We already started the high-dose methylprednisolone again, and then we slowly taper it off. But on March, again, the patient got hospitalized, and again, the methylprednisolone was stopped with the internist. So he had a flare-up. Visual acuity dropped to light perception on right eye and hand movement on left eye. But after we started the methylprednisolone again, then we got the patient under control, and the visual acuity got back again. On his last follow-up on July 3rd, visual acuity got back to 20/160 on the left eye. His IOP was good, under 20, without any glaucoma medication. He was still on methylprednisolone 8 milligrams. We were actually thinking about doing phaco on the right eye, probably over the next month or two. But as it turns out, it became actually the last follow-up of the patient because I just learned last week that not long after we met him for the last follow-up, he passed away due to what was presumably a COVID-19 infection. So this is a patient with focal disease, and if we use this diagnostic criteria, then he have complete VKH, and we met him during a recurrent chronic stage. And glaucoma in VKH disease, it can have present in 6 to 45% of cases, and it usually due to posterior synechiae and pupillary membrane formation, just as what we found in this patient. And patients often need trabeculectomy, and the results reported by Awai et al. Is actually pretty good, with 71% of success in 2 years. But in this patient, we don't really know again. Okay, the lesson learned from this patient is that uveitic glaucoma can manifest differently between eyes, and that even in a VKH patient, as it turns out, total obliteration of anterior chamber is possible. And because it can manifest differently, then treatment strategy might be different between eyes of the same patient. And that if inflammation control is crucial, because flare-up can happen at any point. Too bad that this patient we cannot reach rheumatologist because we need to travel to the capital city of Jakarta to do so. It wasn't be able to do it with the pandemic going on. And the why I choose this particular patient for this presentation, because me as a young ophthalmologist, I learned so much from this patient, especially from the right eye. You know, when he first came, it was a very hopeless eye with edematous, no ACs, and I put it on my IG, and I remember asking people to chime in what to do with this patient. I remember Chai, who is in our audience today. She said, just refer it to your worst enemy, because at that point, I'm not sure any ophthalmologist would want to touch that eye. But as it turns out, even in the most hopeless eyes, there is hope. when we can do it. And also happen again in the left eye when we choose to do phaco even when the inflammation is still, well, not really under control. So it was a really privilege, and I'm very thankful that I got to have the opportunity to help improve this patient's quality of life during the last months of his life. And I hope this is what other young ophthalmologists can take away from this case, that even in the most hopeless eyes, there is hope. Okay, thank you.
Thank you, Dr. Anandita. Thank you for excellent presentation. It's an always honor to invite Dr. S.K. Fang again. Sir, your panelist
Yeah.
comment.
Thanks, Ashraful. Thank you, Dr. Vidya, for a nice presentation. It does illustrate how we can manage patients with a difficult situation, and you have done it very well. And this case also illustrate the problems that we have in patients that comes from a rural area, and we do encounter that in many parts of Asia Pacific. I mean, not only in Indonesia, even in Malaysia, and I'm sure Philippines, Bangladesh. We do have patients that have difficulty coming to for follow up, and especially during the pandemic. I mean, even without the pandemic, I think if the patient need to take a bus, like what Dr. Vidya mentioned, for 3 hours, 3 buses to reach them, to reach the eye specialist, it will be a problem to manage this type of cases. And you have shown that even the anterior chamber is flat, and because of the membrane, you have done a very good job in doing a trabeculectomy in this difficult eye, and managed to do a surgical trabeculectomy and bring the pressure down. And you can see in VKH, patients have ongoing uveitis, and even you do a laser peripheral iridotomy in the left eye, and it's still closed because of the ongoing inflammation. And it also illustrates that the patients with VKH, the systemic management is very important, and you have to refer to the rheumatologist or the physician. But again, this case illustrates that the systemic steroid was stopped. So that is another problem. If the patient is not, I mean, the physician is not familiar with this type of condition, and if they stop the systemic prednisolone or the systemic steroid, the inflammation will come back. And also, I think you didn't mention about the retinal uh, uh, findings, because I think it was difficult to examine, but patients with VKH do have retinal problems as well, and normally we would co-manage with the retinal specialist, but the treatment is still giving topical and systemic steroid, and make sure that they don't have choroidal or retinal problems. And I think finally, in uveitic patients, I think you managed correctly that we prefer not to give prostaglandin analogs, because they can actually aggravate the uveitis. And for cataracts management in patient with uveitis, you have shown how to do a good phacoemulsification with the iris retractors, and probably you need to be careful to protect the endothelium in patients with a shallow anterior chamber. And I think you have managed this patient very well. Unfortunately, due to COVID, patient has succumbed to COVID. So that's all my comment.
Thank you, Dr. Fang, and thank you for giving and sharing your valuable time with us. Now, our next speaker, Dr. Ruhi Mannan. She is the executive member of Bangladesh Young Ophthalmology Society, and she is the scientific secretary of Bangladesh Glaucoma Society. Her topics will be to be or not to be drug-induced angle closure glaucoma. Dr. Ruhi, please share your screen.
Thank you, Dr. Ashraf. Is it visible?
Yes.
Okay. Welcome you all to my presentation, to be or not to be. That is the question. I am Dr. Ruhi Mannan, currently serving as consultant glaucoma at Bardem General Hospital, Dhaka, and I'm a member of Bangladesh Young Ophthalmologist Society and Scientific Secretary of Bangladesh Glaucoma Society. As of now, I have got no financial disclaimer regarding this presentation. We all know that glaucoma is a silent thief of sight, but is it true always? Sometimes, in cases of angle closure, where there is high-rise IOP, the symptoms leads the patients to the doctor, which is a blessing in disguise in some senses. And that point of time, glaucoma doesn't remain actually silent. It becomes the violent killer of the sight. My story begins such that it's a 22-year-old young lady. She was a college student. She visited an ophthalmologist for her eye complaints to take her spectacles, and there she was prescribed medication for headache as well, a few weeks for which she was taking. And then after starting those medications, she started having a reduction of her vision, even with her recently corrected glass. And then she developed colored halos around light, which she was watching very frequently. With these complaints, she was then referred to the Neuroscience Institute of the city. There she was visited by the neuromedicine specialist. They again, after continued the previous medication prescribed by the ophthalmologist. And after continuing those medications, she developed repeated vomiting, worsening of her vision, eye ache, and headache. At this condition, this patient came to our emergency, and there we visited her in our outdoor. It was a very brief examination because the patient was a bit dehydrated and a little unstable. So what we had in her eyes is that a vision of counting fingers in both eyes. The anterior chamber was very shallow. Gonioscopy revealed a grade 0 angle with appositional closure and high-yielding IOP in both eyes, although the fundoscopic examination didn't reveal any abnormality at all. So when we were taking history, what we saw is that after months back, she first visited the ophthalmologist. She was diagnosed with a case of migraine and was prescribed with tablet topiramate for twice daily and to be continued. And then when she was referred to the Neuroscience Institute, there again, she was diagnosed with a case of headache. And then she also again received tablet topiramate twice daily to be continued. So we got our culprit in hand. It was actually the topiramate that was causing acute angle closure. Now, a few words about the topiramate. We all know it's a sulfur-derived drug commonly used for anticonvulsant, but nowadays it is becoming increasingly popular for prophylaxis against migraine-like headaches. So topiramate was causing the angle closure, although it's a rare adverse reaction, but certainly it's an emergency. And if it is not promptly diagnosed and managed, it can cause permanent loss of vision. Regarding the pathophysiology, it occurs in 3 out of 100,000 population. But the important part for which I have selected this case is that with an 180 million people in Bangladesh, half of which is female, and half of that female population is young. And they are commonly come to the doctor for headache-related complaints. And this population is, I think, is increasingly prescribed with topiramate-like drugs, thereby, although it's termed as rare, but nowadays we are getting a little increased number of these cases in our common practice. So what it does is that it causes a ciliochoroidal swelling. As a result, there is an increase in the retrolenticular pressure. The lens iris diaphragm moves anteriorly, causing the acute angle closure, induces myopia, and there is also proposed some degree of inflammation. Keeping this pathophysiology in mind, we started our management. So I'm going a little bit retrograde, showing the management first and investigation later to put the drama on hold a bit. I first encountered this case while I was working with my mentor, Honorable Professor M. Nazrul Islam, sir. And so when you manage such type of cases under supervision of your senior, that's a different thing. And when you put it in, individually in your own practice, it really becomes to a paradox, because in a classical angle closer, which is of primary variety, you always think about pilocarpines, we always think about doing an iridotomy and all sort of things. But in this case of topiramate, this was all exactly opposite. We had to stop topiramate. We started aqueous suppressants, namely timolol, brimonidine and brinzolamide and oral acetazolamide as well. We gave cycloplasty, which is the most important thing here because it would push the lens iris diaphragm backwards. We avoided myotics because myotics would further aggravate the lens iris diaphragm forwards. We prescribed steroids, which would reduce the inflammation, and we preferably avoided any kind of prostaglandin because it would further increase the inflammation. And certainly, as there is no role of laser peripheral iridotomy, we avoided it. So the whole management is a little bit of paradox compared to that of any classical angle closure case. Here is my drama. So in the second day, when we did the refraction, the patient was having an intense high grade of myopia, about 5 to 6 diopters. But when day 15, when she came for later part of follow-up, there was no myopia, it's all gone. The color fundus photograph, there is no abnormality in the fundus apparently, and the OCT was quite normal. This is the UVM picture that we got in the second day when the patient was just starting receiving her treatment. We can see the angle is quite narrow. The lens iris diaphragm is pushed forward. The ciliary body is quite swollen up in both eyes. And in the 15-day follow-up, she came again. We did the review ultrasound by microscopy. The angle is wide open. The lens iris diaphragm pushed backwards and ciliary swelling has reduced. So this is what we got at day 15. Initial visual acuity was counting finger, which has reverted back to 6/9 in both eyes. The anterior chamber became deep. IOP has reverted back to 12/14 in both eyes with medication, and angle is open. Some words of wisdom from a few literatures. Topiramate, it may be associated with ciliocaudal effusion with forward displacements of the lens iris diaphragm. Bilateral angle closure is possible, and usually bilaterally it occurs because it's common source induced. The myopic shift, the ultrasound findings, all document for the ciliary body swelling. There are severe cases of topiramate response better to mannitol and methylprednisolone. And all findings are reversible if recognized early. Peripheral iridotomy has no role in such type of angle closure. So to give a message as a young ophthalmologist is that the young ophthalmologists are meant to be drastic, indulgent, and very prompt and doing a lot of things. But sometimes not doing a lot of things, not to panic, only to think, sit off, to go with the flow, and that makes the patient more happy than doing a lot of things. Not doing is the best thing to do in such type of cases. That's what I learned from this case. Thank you.
Thank you, Dr. Ruhimannan.
Okay. Thank you, Dr.
Thank you, Dr. Ruhimannan. It was an excellent presentation. It's now time to invite our favorite, Professor Zakia Sultana Shahid Madam, for her panelist comment.
Thank you, Dr. Ashraf. Can you hear me?
Yes, madam.
I think Rui and her patient have played an excellent drama, and with successful drama, all the problem he came to meet it up. Thank you, Ruhi, for your excellent presentation, and thank you to present it very nicely and picking up a rare problem. Really, it is a problematic case to face. With due respect to all my seniors, Professor Aba Hussain, Professor Nazrul Islam, Dr. Fang, Muqtadi sir, I'm giving my comment. Topiramate is a very interesting drug, and it is commonly used by the medicine specialist and neurologist and the psychiatrist. And I work in a comprehensive hospital, so I faced several cases came to me with topiramate induced acute angle closure glaucoma. And the thing is that actually the topiramate is used for anti-epileptic, antipsychotic, and migraine. Sometimes we eye specialists also use it for migraine problem. So the message what Rui has been given in her presentation is that whenever any case comes to us, we must listen to the history of the patient with all our patients. So listening to a history is a very important to us because the history gives us several information. Now, second, the workup. The examination of the patient should be done very nicely. And I learned it from my mentor, Dr. Chandra Shekhar, when I was in LVPI. He used to tell me always, see each and every segment. You can get information from each and every side. Then comes to the investigations. I think the investigations, what we give, we should be very cautious while giving investigations. We should not give excess investigations, but thinking and on examination, on history, we have to give it, because with piling all these things, we will get the information and which will give us a route for treatment. So diagnosis is very important. And why I'm telling all these things, topiramide inducing angle-closure glaucoma is very, very confusing to separate it from acute angle-closure glaucoma. Because what is happening here choroidal effusion is there is uveal inflammation, choroidal detachment, relaxation of the zonule, and iris lens diaphragm coming forward and pushing, narrowing the angle. At first, whenever we will see this case, it should struck in our mind, the vision abruptly falls. It comes to the counting finger and patient becomes myopic. So this is one thing. We must see the anterior chamber because sometimes there can be uveal inflammation there, and see the angle and the investigation, which will give us a guideline. That is, we can do ultrasound biomicroscopy or anterior segment OCT, which will help us to see the effusion. And seeing all these things, we can make a planning of treatment. But before going to this, I should say the history, we should take a history, because here the history is another guideline. And without history, without listening properly, we cannot treat it. And the treatment of topiramide-induced angle-closure glaucoma, topiramide-induced secondary glaucoma is totally different, because we will give anti-glaucoma drug, we will give mannitol, the pressure is reducing, but not that much. What we want, okay, we want it in lower teens, but we will not be able to reduce it. And the other thing is that we have to give cycloplastic drug, which is very important. In angle-closure glaucoma, we don't go for cycloplastic drug. And another thing, we have to give steroid, which is common in angle-closure glaucoma and here also. But without seeing all these things, if we do PI and if you go for surgery, that will be blunder for the patient. So my message is that before going to any treatment, we have to see the patient with patience, and we have to work it out. We have to go for investigation. Then we think and do the treatment. Thank you.
Thank you,
Thank you,
madam.
madam.
We are very happy to have with us Dr. Digvijay Singh. He is the president of Young Ophthalmology Society of India, and we all know Yoshi has been supporting and collaborating BIOS from the very beginning and from the very first day of Bangladesh Young Ophthalmology Society. So I must thank Dr. Digvijay Singh and Dr. Divakant Mishra for this. Dr. Digvijay Singh, he is the director of Noble Eye Care Gurgaon, and he is the head of the department of Narayana Super Specialty Hospital Gurugram, and he is an ophthalmologist specialized in pediatric ophthalmology, glaucoma, and neuro-ophthalmology. He will be speaking on a very interesting topic on artificial intelligence, glaucoma software, RIAG, an automated tool for glaucoma detection. Dr. Digvijay, sir, we are happy to have you with us. Please share your screen.
Thank you, Dr. Ashraful. It's indeed a pleasure, and I'm thankful that you've invited me, and I'm being here. My regards to Professor Ava Hussain, Madam, all the office bearers of the BIOS, all my friends, seniors, and all my OC friends and colleagues, and you as well. So it's a pleasure for me to be here. It's an honor. So I'm going to be talking about today about a little different tool, something that I have worked to develop over the last few years, along with another team, and I'm also co-founder of one of the companies which has worked on this tool. But the idea I'm also wanting to introduce is artificial intelligence in glaucoma. And as I think we were discussing right in the beginning, that there's a need for us to come up with new ideas, a need for us to innovate and see how we can improve this process of glaucoma diagnosis. So this is a software called RIA-G, which takes its name from Retina Image Analysis - Glaucoma, because there is also a RIA-DR, which is the diabetic side of it. And the reason we need something like this is because we have more than 60 million glaucoma patients in the world, and the number is growing. And in India itself, we had about 12 million plus. I'm sure Bangladesh has a large number of patients as well. And this is a blinding disorder. And we know that just looking at the IOP is not enough. It's not a good screening tool. You have to look at the optic disc. And that's where the problem comes, that requires a lot of human resources. You need doctors to be able to see it, people who are specialists who can diagnose. Unfortunately, they're in short supply. Telemedicine has been tried, but it's not really a solution, because again, in telemedicine, you need somebody to be reporting it at the back. So there is a human involved, and the number of man hours required are huge to screen a bigger population. So the solution is to have portable cameras, have portable tonometers, and then have an AI solution which can do the job for you. The machine which can at least screen and then get only those patients who are suspect in for an examination by the ophthalmologist. Now, in glaucoma, a lot of work has happened in the field of artificial intelligence, and essentially all of this is aimed at either diagnosing changes in the optic disc, or looking at changes on the visual fields, or looking at progression, where in an automated format, the machine is able to tell you that this looks like something which could be glaucoma. You need to look a closer look at it. And without going into too much detail about the tools of artificial intelligence, we need to know that there are different forms. The most common types are machine learning, where you teach the machine to look at certain pointers and then make a diagnosis or then make an output. Or then there is other forms of deep learning or artificial neural networks, where the machine itself can actually diagnose based on lots of images what the main problem is. Or then there is a black box method, where you put in 100 images and let the computer decide what is the factor which creates glaucoma. So there are different ways of doing it, but it's very simplistically putting it. And our software is based on machine learning as well as deep learning algorithm. And of course, all these AI softwares and this software that I'm talking about is also not a standalone tool to diagnose. This is a screening software which can guide the clinician. So it's not a replacement for the clinician. You could look at these papers I've just put up. It's a very busy slide, but so many papers have come out in trying to do automated disc damage analysis, and most of them look only at the vertical cup disc ratio. And over time, we realized that we've kind of made ourselves better and better at looking at what glaucoma is. Now, RIA-G is basically an automated tool, like I said, which is having, it's got an AI component to it, but also has a deep learning. So it learns on its own, it teaches itself, it corrects itself, it makes whatever mistakes it makes. If you point it out, the machine will try and learn and correct itself from that. And essentially, it's a tool which will automatically try to mark out the disc damage that is there. And it's a patented algorithm, and it works over a cloud system. And I'll show you a video of how it works. Let's hope this is working. So this is going to a website called scanai.app. So scanai.app, and you'll all have free access to this at the end. I will give it across to you. So you go there, you make a doctor dashboard. So you can log in with your email ID, create a login. You select the software, choose any image, of a fundus that you've got, which has got the optic disc in it, of course. And the machine starts to analyze it on the server. This is at a cloud-based server, which is elsewhere in another location. As the machine is analyzing, it is going to look at different parameters for you. It's going to give you the vertical cup disc ratio. It's going to give you the horizontal cup disc ratio. It's going to give you the average cup disc ratio. It will also mark out the disc for you. It will mark out the cup for you. Mind you, this marking is happening on the basis of the kinks in the vessel, not just the color. It will also mark out the ISNT, the neuroretinal rim. Is there a violation or not a violation? As you see here, that there is a large vertical cup disc ratio. It is marked it in a red bar on the side here, if you can see. And the ISNT rule is also violated. So the inferior should be thicker than the superior. The nasal should be thicker than the temporal. If there's a violation here, as you can see in the inferior superior, it is marked as a red. And it gives you a very important parameter, the DDLS, so the disc damage likelihood score. And this score is going to tell us this is how much of the disc is damaged. And this can also kind of guide progression in the future. So I'm just showing you a few examples. Look at this. This is a a little abnormal looking disc. You can see here there's some peripapillary atrophy, a few myelinated fiber. There are some pigmentary changes in the retina. Something like this very often can get confusing for at least for beginners to look at. So here the machine is easily picked up that there's a very small cup, there's a very low DDLS of 1, there's no glaucoma whatsoever, everything is marked in green, the glaucoma probability is low. Let's look at another example. Again, a small cupping here, you can see how beautifully the machine has marked it out for us. It takes about a few seconds to do that processing. This is another case. You can see here how there is a notch in the cup inferiorly here, and the machine has picked that up, and it has given us that the disc damage likelihood scale is 4 here. And even though there is a large vertical cup disc ratio, but it has put the glaucoma probability at a medium level. So it is higher. This is a higher probability of glaucoma than the previous, even though the vertical cup disc ratio is similar to what maybe will come across in some of the future images. And you can see here that I've just put a little at the bottom from the DDLS scale for you to just compare that how this machine is picking it up. It looks at the narrowest rim width and the clock hours in which that is, and then picks it up there. Now this is again another disc, myopic looking, large cup, as you can see here, large cup, large disc. But again, the DDLS is not very high. This is probably a large physiological cup, and there is a mild ISNT violation. This is another disc. I'm just running through these. You can see here now this disc is showing a higher DDLS score. There is possibly a high chance of glaucoma. Such a patient, the machine would recommend should go out and get checked by an ophthalmologist. There is an inferior thinning, and you can see the typical double hump that should come in the neuroretinal rim is not coming here. It's almost showing as a single hump. Again, a very thin neuroretinal rim, a high DDLS score here. Remember, sometimes just the cupping alone doesn't work. You have to look at all these parameters. And the advanced version also takes the IOP, the family history, and other things to give you a complete diagnosis. Again, another one of those images. So even if the images is a little fuzzy here, as long as the disc is clear, it'll be able to pick it up and it'll be able to mark out the cup disc ratio. In marking in red means this is abnormal. Here you can see because the ISNT violation is very borderline, it's kind of marked it in a black color here in the chart as well as in the ISNT box. So it says that you need to look at this a little more closely yourself. The machine is saying I'm not too sure whether it's there or not there. So rather than give a wrong error, it'll give you a black mark there for you to look at it. Let's look at another one here. Again, a big cup, big disc, but low DDLS. You can see the neuroretinal rim is showing a double hump sign, but there is a violation there. Here's another one. You can see such a lot of peripapillary atrophy again, but still it has been able to pick it up. So these myopic discs, where we sometimes get confused ourselves, the machine is able to still pick it up. And that is not to say that there are bloopers. We'll come to some of those as well. Here you can see a very large disc, a very large cup, almost concentric cupping. As you can see, the DDLS score is high, a very thin neuroretinal rim. You can see the chart, the graph here, the neuroretinal rim graph is almost flat. So again, all these are a high probability of glaucoma. A large cup here again, a large disc, but a concentric cup, more of a physiological myopic disc, as you can see, so less of a glaucomatous disc, but so the machine is marking it. However, something like this would still need to be referred to a clinician for the final analysis. Again, a little hazy picture, but it does analyze it for you. There is also a dual mode where you can analyze both the eyes together, and it also gives you a certain parameter which is known as inter-eye asymmetry. So you know that in glaucoma, asymmetry between the two eyes in cupping is again a parameter which makes us more suspicious of glaucoma. So this tool, you can run two images together and it gives you an inter-eye asymmetry in the pro version. And if we run the same image twice, you can see that the inter-eye asymmetry is very less. So it's kind of fairly accurate in its retest variability. Let's look at these bloopers. So sometimes if the image is too pale a disc, the vessels are a little obscured, or there's a disc edema or something like this, you will get random image values. So one has to be careful. There's no software which is 100% as of yet. We did a validation of this, so the aim was to look at these parameters and compare these to what ophthalmologists would do. So we took the machine, we fed it with about, I think, 275 images or so, probably 250, I'll come up to that. And then we also gave the same images to the ophthalmologists to look at the pictures and to give their parameters of the vertical cup disc ratio, the horizontal cup disc ratio, whether there was an ISNT violation or not, what their scores were, their DDLS scores, and we compared them, with what the machine took out. Of course, the images had to be clear ones. The fuzzy ones like this were not accepted. And we had a cupping somewhere in the ratio about, so from 0.2 to 0.9 cupping, the images had a large amount of cupping. Most of the discs were average sized, as you can see in the bottom of the table here. Some of them were small, some of them were large. This was basically to have the DDLS, because the DDLS requires the disc size to go as well. As you can see, there was great correlation between the ophthalmologists as well as the Riyaji outputs. You can see that there was There's a bell-shaped curve, of course, for the cup-disc ratio. There was a subtle, less than a 0.05 difference in the cupping that was there. The Bland-Altman plot shows good correlation. Similarly, even for the horizontal cup-disc ratio, there was a good correlation. When we looked at the ISNT violation, we can see in most of the cases, the ophthalmologist as well as this Venn diagram is showing the RIAG agreed. Yes, there were a few outliers on both sides. That is true, but there was roughly about a 70 to 80% correlation on the ISNT violation. And we are, I think the company is working to improve on that further. When you looked at the DDLS scoring, in majority of the cases, there was no difference between what the software chose and what the ophthalmologist had chosen. And within one stage of that, you could practically almost 90% of the patients came within one stage of that. So the results were pretty good. Overall, if you look at the accuracy, it was above 90%. The specificity was 95% plus, I think, about 92%. Specificity sensitivity was 82%. And the negative predictive value was very high, so 96%. The positive predictive value was 63%. So if the software said this is not a glaucoma, there was a very, very high chance that this was not a glaucoma. So this is the paper you can read. I've rushed through the results in want of time, but you can go. We've published this paper now in the Indian Journal of Ophthalmology, so these values are easily available. And like I promised, so all of you can go and log on to this website, https scanai.app. Go there, make an account. For all of you, it's free. Upload your images, and at least for the residents and the students and followers, you can actually do your judgment of cupping. Upload an image and see, is it the same? Where did you go wrong? Where did the machine go wrong? And it's a good learning process for you, as well as you can use it in your practices, because sometimes when you want to look at progression, you can run the same as objectively through a screen versus your own intra-observer variability. So, and if there's any problems, please feel free to email me, and we'll sort that out for you. And I think with that, I'll get this talk to an end. Back to you, Ashok.
Thank you. It was a very interesting and excellent talk. Thank you, Dr. Digvijay Singh, for sharing this with us. Now I would like to invite Professor Iftekhar Mohammad Munir. He is the head of the Department of Glaucoma of the National Institute of Ophthalmology, the parent organization in Bangladesh for ophthalmologists. Sir, please.
Dr. Ashraf,
Sir.
Professor Abha, I like to leave due to back pain.
Sir, thank you, sir. Thank you, sir.
Thank you, sir.
Okay, please.
Yes.
You take rest.
Thank you. Thank you all. Thank you.
Thank you, Professor Muqtadir, sir, for giving you time with us. Professor Iftekhar Munir, sir, please.
Thank you. Thank you
Am
very
I
much.
audible?
Yes,
Am I
sir.
audible?
Yes, sir, you are audible.
Thank you, Dr. Ashraf, and also many thanks to Dr. Digvijay for excellent and informative presentation. It is always a pleasure and honor to me in a nice webinar, especially in presence of my teacher, Professor Abha Madam, Professor Muqtadir sir, renowned international legend of ophthalmologist Dr. Fang, and Professor Ahmadul Islam. Dr. Digvijay Singh highlighted the artificial intelligence. What is artificial intelligence? How it works? What is the field, or what is the goal of artificial intelligence in glaucoma? They nicely describe it. Actually, artificial intelligence main importance in glaucoma. By artificial intelligence, we can diagnose glaucoma early, so we can preserve the patient vision and give this quality of life to the patient. And on the other aspect, in the doubtful cases when glaucoma in borderline or glaucoma suspect, artificial intelligence helps the clinician what is the diagnosis, what will be the plan of treatment of that case. Artificial intelligence help the clinician to diagnose the case and check out the treatment plan. So it is very important for the glaucoma clinician. But it also helps in the follow-up period also. It can diagnose whether the patient is static or it is progressive. It also predict if the patient is in probation, what will be the clinical scenario in the next 2 or 3 years It also helps in patient compliance and drug adherence because the patient can see his documents, clinical documents in the computer screen. So it also helps in counseling. And another thing, very important thing with glaucoma screening, as the user, saying, let's say that it is related with the cloud. So in the screening phase, small instrument like visual field or imaging technology tools can be carried to the screening spot, and we can do the screening very effectively, and we can analyze this data very effectively. But till now, it is in learning. It has. I hope in future, by technological improvement, its diagnosis tool is validated without clinician. Dr. Digvijay Singh nicely described artificial intelligence obvious tool, how it works with retinal image and this finding with cloud-based technology, and was very much benefited from his presentation. Nice job. I would like to thank once again Dr. Digvijay and also to the concerned person of this webinar, especially Young Ophthalmology Society of Bangladesh for inviting me and giving me the time to stay in this panelist. Thank you, everybody. Be safe, stay safe.
Thank you. Thank you, Professor Iftikhar Mohammed Munir, sir, for staying with Bangladesh Young Ophthalmology Society. Now, our last speaker of the webinar, Dr. Bipul Kumar Desharkar. Dr. Bipul, he is a great leader and he is the General Secretary of Bangladesh Young Ophthalmology Society. He is the Publication Secretary of Bangladesh Glaucoma Society, and he will be presenting on the longest journey, a battle with refractory glaucoma. Dr. Bipul, please share your screen.
Thank you. My screen is visible?
Yes, your screen is visible and you're audible.
Okay. Good evening, everyone. Welcome to all my presentation. I, Dr. Bipul Kumar Sarkar, Assistant Professor of Isfahani Islamia Eye Institute and Hospital and General Secretary of Bangladesh Young Ophthalmology Society. In today's webinar, my glaucoma practice, I am going to share a journey of one of my patients with refractory glaucoma. Actually, this was a history of journey of a one-eyed patient who had already history of multiple surgery in that eye. And also I need to do multiple surgery for managing these cases. Actually, patient reported in our hospital with corneal ulcer, and this ulcer was poorly responsive to medical treatment. That's why conjunctival hooding was done our cornea team. But after few days of conjunctival hooding, conjunctival tissue become necrosed and cornea become exposed and threatening to perforation. That's why urgently therapeutic penetrating keratoplasty was done in that eye. Initially, patient regained after his vision after penetrating keratoplasty, but gradually he reduced his vision because cornea become edematous and lens become cataractous. When I received the patient, I have seen there is a high uncontrolled intraocular pressure despite maximum anti-glaucoma medication, and cornea become edematous, and there is thin microcystic bulla over the cornea, and epithelium was not intact. And on gonioscopy, I found there is a totally distorted angle and the formation of multiple peripheral interior synechia in the angle, and lens becoming cataractous, nuclear sclerosis, and posterior subcapsular cataract was there. And I tried to examine the fundus with hazy media, and I have seen there is already advanced glaucomatous cupping in the eye. That's why I was worried to finding a solution which one is the best surgical option for this patient, because you already know patient is one-eyed patient and there was a very compromised graft tissue. There is an unhealthy epithelium and low endothelial cell count, and there was a high IIP despite maximum medical medication, and there is also cataract. And another important thing is that his conjunctival tissue was not healthy, because though he has multiple history of surgery like conjunctival hooding, there is a scar tissue overall all the conjunctiva. That's why which one is the best surgical option, either only filtration surgery or filtration surgery with cataract extraction or valve implantation with cataract extraction. Finally, I decided I will go for glaucoma drainage device implantation with phacoemulsification with posterior chamber lens implantation at the same setting. And during the surgery day, I started my surgery nicely, and after traction suturing, I was searching which side I can place the bulb properly, because there is a conjunctival tissue was not healthy. There is multiple scar formation about the whole conjunctiva. Finally, I find out the superior temporal portion was comparatively healthy and less scar tissue, and I placed the bulb in superior temporally. After conjunctival peritomy and priming, I placed the bulb plate and I secured the bulb plate with nylon. And after securing the bulb plate, I also secured the tube with same nylon. And after securing the bulb plate and tube, I usually use scleral press gap for covering the tube also. And after securing the both bulb plate, tube, and covering the plate with scleral space gap, I cut the tube with, after proper measuring of the tube, with trimmed bevel wrap, and then time for phacoemulsification. You see, the first challenging part was doing capsular axis, continuous capsular axis, because visibility was very poor. I can't see the capsule properly, but luckily I do the continuous capsular axis. Fortunately, the lens material was soft, because only posterior subcapsular or big cortical cataract was also. That's why I was very careful for protecting the endothelium, and I easily removed the lens material just using aspiration and vacuum. I didn't use phaco power at all. So I didn't face any difficulty during phacoemulsification. After properly removing all the cortical matter, I implanted hydrophobic intraocular lens within the bag. You see, I'm doing phacoemulsification, and now I am placing intraocular lens and I place the intraocular lens within the bag properly, and then I enter into the AC with 23 needle, and then I enter into the tube within the indoor chamber, and I keep the tube away from the endothelium, though their endothelium was very compromised. Then AC formation was done. All the step was done nicely and uneventfully. That's why I was thinking the light may be seen at the end of the tunnel. Finally, patient again regained his vision. There is an improved visual acuity, and corneal tissue was very clear, and bulb and tube was properly placed. There was stable, normal intraocular pressure without anti-glaucoma medication, and most importantly, patient gained his comfortable eye, because there is no discomfort or any other symptom. I managed this type of few cases with refractory glaucoma cataract by doing combined phacoemulsification and Ahmad valve implantation at the same setting. And few journal I published, and one of journal in Journal of Glaucoma, they reported that it was a very safe and effective surgical option. And most importantly, at the same time, it provides good visual rehabilitation and good control of intraocular pressure. Thank you. Thank you so much.
Thank you, Dr. Vipul. It was a nice presentation. And now I would like to invite our President of Bangladesh Glaucoma Society, Professor Muhammad Rizanur Rahman sir, for his valuable comment. Sir.
Thank you, Dr. Ashraf. Good evening to everybody. And first of all, I give thanks to Bangladesh Young Ophthalmology Society, those who have organized this nice international webinar. And today, actually, we are very much lucky that two ophthalmic leaders of this Asia Pacific region is with us. Professor Abha Hussain. She is our mentor, our guide, and we always feel encouraged in presence of Madam. She is going to be president of APO. Another is Dr. S.K. Fang. She is a very good well-wisher for Bangladesh ophthalmologist and for Bangladesh Glaucoma Society and also for Bangladesh Young Ophthalmology Society. And in this webinar, all the foreign faculties, dignitaries, they have nicely present these presentations. And lastly, I have nothing to say regarding the Vipul's presentation. I don't know how much the patient was lucky and how much Vipul was powerful to fight in this battle. Really, it was a very challenging, very challenging. Among all these presentations, I think it was a most challenging case. Nobody will do like this. From corneal ulcer, perforation, PAS, glaucoma, PKP, glaucoma, cataract, advanced optic disc damage. Taking all these challenges, how nicely he managed this case. Really, it was a battle. Really, it was a battle. And from this presentation, we must have some learning. Learning is that I think we must give proper attention to the patient. And we have to take the patients for management of this patient. And we always think if it is very difficult to manage, we should refer this patient to proper place so that at this 11th hour or at the last stage, we can save the remaining vision and we can save the eyeball. It was a very difficult case. One of my experience, I have done PKP, and that was a case of keratoconus. But after trauma, the cornea, the stitch become removed and the cornea become removed and the lens that comes out through the pupil. Again, I do PKP and that patient develops secondary glaucoma. And the management, it was very difficult. And finally, I could not save the eyeball. The corneal edema, the pain, everything, uveitis, and finally lost the eyeball. And today, during the presentation of Vipul, I was remembering that fact. That was in my early practice life that was happened. Today, I learned so many things from Vipul's presentation that we should take patience and we should give the proper attention to the patient. Then finally, we may save the patient's eye or we may save the vision. Thank you all. And lastly, grateful to Young Ophthalmologist Society under the leadership of Professor Abha Hussain and Professor Sharbuddin Ahmed. They are going forward and they are arranging such type of webinar, and all these webinars I think will helpful for young ophthalmologists to grow up themselves in future. Thank you all.
Thank you, sir.
Thank you, sir. Thank you. Hope your advice will be always with us. Now we are opening the question, answer, and the discussion session. So if there is any comment from any of the panelists or any of the speaker, we can discuss. Professor Nazrul, sir.
Thank you, Dr. Ashraf. It was excellent webinar, really. And I must say, the young ophthalmologist presentation was not less than any presentation in international level. So they have done really at per international standard presentation, all 6 presentation, I must say. And of course, we also learned many things from their presentation. And definitely, we must thank the young BIOS for organizing this kind of webinar. and keeping us along with you so that we also feel more younger. That is very important. And of course, our great achievement that our leader, Professor Ababasan Madam, Professor S.K. Fang is also with us long time. So definitely thanks to all of them. And one presentation I must comment, one is Digvijay Singh. His presentation was excellent because of AI. And this is the time artificial intelligence will tell us many, many, many things. And one thing I disclose here is I'm also attached to a multi-center study in Singapore and Australia with the AI. And I do on glaucoma, AMD, and also DR. So hopefully it will be published this year. So it is really coming, this artificial intelligence coming as a new way of learning. And it will really helpful. It will be really helpful for the general people for quick diagnosis. I must congratulate Dr. Digvijay for presenting such a good AI story here.
Thank you, sir. Thank you.
Thank you so much. Thank you very much.
Thank you, sir. Thank you, sir. Dr. Fang?
I also agree with Nazrul that all the presentations were good. I have nothing else to add.
Thank you, sir. Dr. Digvijay?
Can I speak, Dr. Ashraf?
Yes, madam. Yes.
I must thank to the young ophthalmologist also. I do agree with Professor Nazrul and Professor Fang that they are in this pandemic situation, their exercise regarding all these topics and vibrating the scientific knowledge among the young ophthalmologists, these are quite appreciable. And this is with most standard way they presented all the presenter in this webinar. They presented so nicely. I really amazed, and thank you, Ashraf, for inviting me as a panelist, and thank you again.
Thank you, madam. Thank you. Dr. Digvijay?
I think I must congratulate BIOS. You have done a wonderful job. But Ashraful, Vibhul, you guys have been. So however we began, and you've really done a great job for all the young ophthalmologists for Bangladesh. And I think your seniors are great leaders, mentors were guiding you. This is, I mean, sir, hats off to all your seniors as well.
Thank you. Thank you, sir. Munir, sir?
Actually, I am very much proud that today I learned many things, many tips from our juniors, encouraging us. I think in every aspect. In glaucoma today, all the presentations are very nice, very informative. I hope Bangladesh Young Ophthalmological Society continue this sort of in future, and we always give thanks to the endeavor, and thank you everyone.
Thank you, sir. Dr. Vidya? Please unmute yourself.
Thank you for inviting us, Dr. Ashraf and BYOS. It was a great webinar. It was excellent. Stay safe, everyone, and thank you again.
Thank you. Thank you. Dr. Edgar, sir?
Yes, really a great opportunity to participate in this a very unique webinar combining the young and the not so young. How I wish we had this kind of venue and opportunity when we were starting out in our practice. And I think they have the right to be called young because there are also practitioners who we consider as the not so young. So eventually they'll be, we'll be passing the baton on to their ranks, and hopefully they'll also be inspiring the young ophthalmologists as our mentors has inspired us also. So thank you again, and we hope that everyone is safe and that we avoid the virus at all costs.
Thank you, sir. Dear audience, now we will hear from the leader of the Asia Pacific region, the shelter of the Bangladesh Young Ophthalmology Society, our chief patron, our mentor. And I always tell one thing: when I get chance opportunity to talk with Professor Abha Hussain, I always learn something. And I would like to invite, it's an honor to invite Professor Abha Hussain, the chairperson of this webinar and chief patron of Bangladesh Young Ophthalmology Society. We want to hear from you. We want to learn from you, madam. Please.
Everybody has said it was an excellent webinar, really. I'm amazed. And Dr. Fang, Dr. Nuzrul, Dr. Mijan, and all the panelists have accepted this. Dr. Jakia, everybody has said that it was an excellent webinar. But time has also flies, as because it started at 8:30 and now it is 8:37. So I should not take much time, but still I would like to congratulate all the speakers. So nice presentation. And I would like to start from Digbijoy, the very name Digbijoy. That means he win all parts of the world. It's the meaning of your name, Digbijoy.
That is true, ma'am. Yes, it is.
Yes.
It is the name.
So the artificial intelligence really, Professor Nuzrul has said, and the other are also comment that it is, and this artificial intelligence is coming up and we will be very much relaxed and we can have our diagnosis, we can have our all the thing with this artificial intelligence. And I will go with your link, and also I will email you, Dr. Digvijoy. It is very excellent. The panel, Professor Iftikhar Munir, he has also explained it very nicely, and he said that this is very much good thing for all the ophthalmologists to learn this artificial intelligence, as because this artificial intelligence everywhere it is going on now, but in Bangladesh, in the young ophthalmology society bios, they have keep these topics in this webinar. So I would like to thank Dr. Ashraful Haq and Dr. Bipul Kumar, and also the others, Rui Mannan, and all the members of these bios to select the time-bounding topics within this pandemic situation. So thank you, Digvijoy and Dr. Munir. Next, Dr. Bipul, really, one-night case is always from the very beginning of my learning. I am very much emotional to that part, that one-night case, how to save the eye. He has nothing to do. The other eye has already lost. So the way, the longest journey and the battle, ultimately you own. But Bipul, I would like to ask one question. What is the visual acuity? Though you said stable visual acuity, but what is the visual acuity?
Actually, his last visual acuity, best corrected visual acuity was 618, because there was a mild PCO.
618, it is
Yes,
enough for him. It's we can't imagine. 618 is very good visual acuity, of course. Congratulations to you, and also the panel, Professor Dr. Mizanur Rahman. He has also very nicely explained it, and also said that nothing can be said, as because he has done lot of things, from the very sloughing corneal ulcer, perforation corneal ulcer, therapeutic penetrating graft, then cataract surgery, then go for, and in between glaucoma surgery also. And ultimately, we gain 618 vision. So thank you so very much, both of you.
Thank you, madam.
Dr. James Paul Gomez, he was the first speaker, but I am going from the last one. And in the middle, I always write the name from our previous poster. And I just note it, but you were in between my sheet. So James Paul new vascular glaucoma after phacoemulsification. It is really, new vascular glaucoma is very reddest thing, and that after phacoemulsification. So you did a lot of job here. You have shown intracapsular cataract extraction, extracapsular cataract extraction. Still intracapsular cataract extraction is practicing in Philippines?
Yeah. Some.
Right.
Yeah. I've seen
How
a few
many
people.
percentage? How many? How much? How many ophthalmologists are doing intracapsular cataract extraction?
Actually, ma'am, I only saw that done when I was a resident back then. Maybe just a few cases. But with my practice right now, nobody's doing intracapsular extraction anymore.
Right. And Dr. Edgar Leuenberger, excellent comment, and also share his experience. So thank you so very much, Dr. Edgar and Dr. James Paul Gomez.
You, ma'am.
Next, Ruhi Mannan. Ruhi Mannan, to be or not to be, drug induced. This is very, very important, as because the migraine patient are always taking this drug, and just they are coming with the symptom as the acute narrow angle glaucoma like that. So it is very, very important to take the history. Professor Jackie has said very important thing, they take the history, what medicine they are taking. And Ruhi Mannan has explained it so nicely, and Jakia also gave her comment, valuable comment. Thank you so very much, both of you.
Thank you, madam.
Dr. Vidya and Anandita. And Anandita, no, the same name, Anandita. I love the name Anandita. Anandita means joy, joyous. Is it? We mean, Ananda means joy. So it is very nice name. And many phases of uveitic glaucoma. All are challenging cases. Uveitis is very, very important, as because when there is uveitis, and after, in my early life in 1980-81, my mentor, Professor AQSM Harun, he said to me that don't do any surgery within this uveitis. But they have to do the surgery within us, because the something is like that, that if we wait, that means we can't have quite, and then as because of
I think we lost the internet connection from Professor Abhausen, madam. We are just waiting for her to get back to us. So hopefully Professor Abhausen will be back with us very soon.
okay.
Yes, Professor Abhausen.
Am I audible?
Yes, madam, you are audible and visible also.
Okay. So I will not take much time, but thank you so very much, Veda, and Dr. Fang. So nice comment you have given, and it is really very. I don't. Just a minute. My son is calling from Canada. Just I'm canceling it. Dr. Fang, thank you so very much that you are here from the very beginning and give your comment. And that is very important, that peripheral laser iridectomy. And within the ongoing uveitis, this has happening. So both presenter and the panelist, thank you so very much. And the last but not the least, Dr. Salma, excellent presentation, really. And again, I should say that there are so many women speakers and all are very, very good, and all are just don't take it otherwise. I always said that women are very good. They are very good presenter. They are very good surgeon, excellent webinar. But the other, all the speakers did their presentation very nice. So I have explained, hello?
Madam, you are audible, madam.
Okay. So I would like to express my heartfelt thanks to all the speakers, to all the panelists and all the participants. Still now they are sitting for hearing the, now it has already over, and the participant from very high level, it is now lowering down, but we should also end our this seminar or webinar. And now I would like to thank Dr. Ashraful Haq, Dr. Bipul, and all the team member of BIOS for your excellent webinar today's. And all the panelists, thank you so much. All the speakers, thank you so much. Thank you.
Thank you, madam.
Thank you,
you
madam.
for
Thank
your
you.
presence, and thank you for your excellent support to us. And we always say that you are the pillar of our strength. So dear audience, this was our second international subspecialty webinar. So we are concluding here and hope to see you all with our next webinar. Thank you very much. Thank you for staying with us. Thank you.
Thank you.
Thank
Thank
you.
you
Thank you,
all.
sir.